Dr. Deepak Gupta, child and adolescent psychiatrist, founder and director, Center for Child and Adolescent Wellbeing, senior consultant in Sri Gangaram Hospital, and EMDR trained therapist in an EMDR level, first level trainer, chairperson, Child and Adolescent Psychiatry Committee of Indian Association of Private Psychiatry, Golden Aim Awards for Excellence and Leadership in Healthcare, Eminent Medical Person Award, President Appreciation Award of 2010. Sir, kindly take over.
Yeah, good evening everyone. First of all, I want to thank heartful thanks to IAP GDP GDP chapter for inviting me in Chennai for this deliberation. A topic which is very, very close to my heart, ADHD. I know we are at the end part of the conference, so definitely the time and the audience too becomes limited and sparse. But once again, thank you. So I have been given 15 minutes. Let me justify with my talk. Early identification and diagnosis. Let me start with this few vignettes. Very simple. A 4-year-old nursery boy talks a lot, noisy play at home, moves in the class, runs around in the class, and is difficult to manage at birthday parties and shopping mall. Mother reports that his battery is fully charged and even at bedtime, but he's a bright child. 4-year-old. Let's go to adolescence. 12-year-old adolescent girl. She is getting passing marks, but poor concentration, careless mistakes in academics, reluctance to write long paragraphs. She is not hyperactive, but she is lazy, disorganized. People described her as dreamy or daydreamer. Problems with friends and low self-esteem that I can't achieve, I'm not good enough, I'm not like other children, I'm different. Does she have ADHD? Now go to a little higher age, 17-year-old, a teenage, almost in class 11th, almost getting ready for the college, anger outbursts, defiant, fidgety, cannot wait for his turn, frequent fights with the peers, few incidents of rash driving without license, and road traffic accidents, above average in academics, that is his strength, but teachers opine that he can still do much better, he can top the school, and he can be a university and a board topper, and also there's a past history of overactivity in childhood. Does he have ADHD? Yes, all these three examples are of cases of attention deficit hyperactivity disorder, ADHD. ADHD is one of the most common NDD, neurodevelopmental disorder. The prevalence of ADHD in children and adults estimated around 5.3% or 2 to 3% adolescents. So on an average, in every class of 40 students, you will have 1 or 2 children with ADHD who needs intervention and to be identified and given right timely intervention. It runs a chronic course and causes significant impairment across various domains of everyday functioning. It needs a comprehensive assessment because we want to make sure that the long-term functional outcome is not impacted negatively. Now these are the core features: inattention, hyperactivity, and impulsivity. DSM-5 came almost a decade back in May 2013 when DSM-5 came, and now we have reached to the ICD-11. What I want to highlight, because of paucity of time, is that it's a persistent pattern of inattention and or hyperactivity, impulsivity. Either inattention or hyperactivity or impulsivity that interferes with functioning. Because a lot of students you will find, they're little bit inattentive, little bit hyperactive, but their functioning is not impacted. That is not ADHD. Otherwise, we tend to label more and more children with ADHD. So that is what we need to say. A lot of hyperactive kids who have a lot of energy, they are not ADHD because their functioning is not impacted. And also, the symptoms start before the age of 12 years. This was 6 and 7 years before, but now the age has been come to the 12 years. As per the DSM-5, it should be present in 2 or more settings. This is the crux. If it is only present at home, think of beyond ADHD. If it is present only at school, think beyond ADHD. It should be at least 2 or more settings. If it is only at home, think of marital conflict, family difficulties, challenges at home, interpersonal conflict, all the emotional factors. If it is only at school, think for SLD, specific learning disorder, learning disability. That's one thing. So at least 2 or more settings, home, school, work, or with friends, relatives, they should interfere, reduce the quality of social, academic, or occupational functioning, and it should not be explained by other mental health disorders like schizophrenia, other psychotic disorders. That is important. These are symptoms you can, because if I explain you, I won't be able to finish in 10 minutes. So out of 9 symptoms, at least 6 should be present. Inattention or hyperactivity. But one thing I want to read is that 6 or more of the following symptoms have persisted. So one is out of 9, 6 should be there. At least 6 months should be there. 6 out of 9 and at least 6 months, and should be causing dysfunction. But in clinical practice, what happens? You get short of 6 symptoms. You get 4 or 5 which are going on. So a lot of times you don't have the full ADHD disorder, you have ADHD symptoms and features which is also causing dysfunction. That is also. So you may not have able to full the classical textbook practice, but that also is interfering that the child is causing difficulty. So a lot of times we need to identify subsyndromal ADHD also and intervene. Subsyndromal ADHD is more common according to me, and it is mostly missed, especially in the girls. And that is why a lot of girls, when they reach college, they approach now because of the Dr. Google and other platforms, then they identify themselves that I have ADD and ADHD, please treat me because that is causing the problem. So these are 3 prominent types, inattentive, hyperactive and combined. Only if it's highly inattentive, easily distracted, not hyperactive or impulsive, daydreamers, most common in girls. Extremely hyperactive, impulsive, not highly inattentive, that is hyperactive, impulsive. And third is the combined type. All 3 are there. Inattentive, hyperactive, impulsive, highly common. This is the most common thing. Now I want to, ICD criteria are almost similar. ICD 11 has just come recently. The only thing is that they have not specified on the age, and they have not specified 6 out of 9. And instead of 3 subtypes, there are 5 subtypes. The other 2 are other specified and unspecified, where subsyndromal ADHD can be easily put into it. Now, why early diagnosis is important? Because ideally we should not diagnose before the age of 4 years. That is the one thing I want to emphasize in this slide. And it is not, ADHD is more than tantrums. It's not that any child, a 4-year-old or 3-year-old, 5-year-old, throwing a temper tantrum or having a behavioral difficulty or anger outburst is ADHD. No. ADHD is beyond temper tantrums and the toddler problem. So be vigilant, identify them early so that you can put the timely intervention. And this graph is very, very important, which I want to highlight. Yeah. If you see, initially, the hyperactivity symptoms are prominent. As the age goes, hyperactivity and impulsivity slightly start dipping, start going down. Inattention part becomes more prominent. And as that is becoming prominent, the comorbidity, the other psychological issues, emotional issues, depression, anxiety, sleep, substance abuse, all this part, it starts increasing. So sometimes more than ADHD, it is a comorbidity which becomes more troublesome. Let's see what are those comorbidity. These are the various comorbidity. Learning disorder, disability, conduct disorder, oppositional defiant disorder, tics and Tourette's, developmental coordination, anxiety disorder. Anxiety disorder is highly, highly common in children and adolescents with ADHD, especially girls with ADD. Very, very common. And sleep disorders and mood disorders. There are enough papers to talk about sleep problems in children with ADD and ADHD. Now, how do we diagnose? So diagnosis is not that the parents comes and says, my child is hyperactive, inattentive, then we diagnose. No, it is a full comprehensive assessment. And how do we do it? We take information from the multiple informants. Never rely only on parents. You will tend to make mistakes because parents are parents. So that's why, so talk to parents, get information from teachers, and never forget grandparents in our cultural context. Please talk to grandparents if you get chance. You will get so much history about the parent's profile, about the child, a lot of times, whether it's a nani or dadi, whoever it is, maternal or paternal. That's important. And teachers. Teachers never should be missed. So what I do, I have a school information form, I send to the school with the permission from parents, I get the information. After that, talk to the child. Even it's 6-year-old, 8-year-old or 12-year-old adolescent, please spend time with the child or adolescent. Because after that, you will come to know. You will have able to build a good rapport with the child adolescent, and that is very, very important because we know the intervention is not for one day, it's a long, long journey. So after that, once you're able to take this, you're able to identify the symptom, progression, functional impairment in different settings, other comorbidity issues, developmental history, medical history, patterns and related comorbidity, psychosocial history, and school performance. You have a comprehensive idea what you're dealing with. Don't miss this part, the psychosocial part. Very, very important. The psychosocial part is so important. Ask about the mother's mental health, father's mental health, their relationships, what is happening in the house. Because ADHD itself may not be problematic. The contamination, we just heard about the pollution and the other impact. The contamination, not because of pollution, contamination because of the home environment tends to flare up the ADHD symptoms and lead to other defiance, aggression and irritability. That's the one thing. So always address psychosocial factors. And as we start this thing, we need to never forget the physical examination, height, weight, pulse, BP, vision, hearing, screening wherever required. Look for the dysmorphic features and a complete neurological examination, including assessment for the coordination, observation of verbal and motor tics, because tics and tourniquets are very, very common in children with ADHD. Around 1/3 of them have. Now, while you're doing all this, keep a watch. Keep a watch on the child. Look for the behavior. Is he fidgety, unable to sit still, moving here and there? Observe the communication between, because this is the point which will help you to differentiate with autism. As we know, autism and ADHD have a very strong comorbidity. So you are able to see how is the eye contact, how is the joint attention, how whether the child is able to relate, communicate, is echolalia is there or not, any repeated restrictive behaviors are there. All those things will help you to differentiate, and the mood and affect, irritability, and speech and thought process and cognitions. All this you can directly observe. So while you're taking history, your one eye should be on the child and what he's talking, how he's relating. In that way, you're able to do a good mental status examination. Rating scales are there, a lot of rating scales are there which helps you. We know we have Connors, we have CBCL, we have Indian one, Inclen, but the only thing is that Inclen is DSM-4TR based. That's the only thing. Now, there's no laboratory test, we know there's no diagnostic test for ADHD, but yes, some of the things which are usually has been related is the thyroid function test, lead, as sir was talking about, that if your house is before 1950, think about the lead. Yes, lead is very, very common. In USA, certain parts of the USA, there are regular screening for the lead is being done. We don't have it in our country, but yes, I have seen a lot of cases where lead levels are very, very high. Ferritin, don't ignore ferritin. Ferritin should be more than 50 nanogram. That's very, very low. Ferritin of 10, 12, 15, 20 can go on. Inattention studies, we have enough studies are there to prove that, especially in the girls part. And ECG is not needed, neuroimaging is not needed unless you're dealing with a refractory ADHD case who is not responding to anything. Now this is my last slide. Very, very important. I have 1 minute and 30 seconds, so I can spend more time easily here. This slide is very, very important because ADHD, a lot of times, things looks like ADHD, but they are not ADHD. A child who is restless is not always ADHD. A child who is fidgety is not always ADHD. ADHD can be look like ADHD. So what could be various possibilities? One thing we have to rule is this, the developmental variation. It must be a developmental variation. Little bit child is fidgety, no other problems. The child is doing well. Parents could be more concerned or over concerned, as sometimes. And the parents may be too anxious. They would have read something on the Google, they would have heard something. So we need to see whether it's just a developmental variation. Autism spectrum disorder. We need to see that because we know autism, a lot of time present with significant hyperactivity, is the core symptom of social interaction and RRBs are there. Then we have to see which is more prominent. And that is what is there. That's why medication which I use for ADHD does not have that much of effect size in autism, unlike without autism. So same medication which shows 70 to 90%, in autism, along with ADHD, it shows 20 to 30%. That's why we should be very, very careful when we are using stimulants with autism, with ADHD. Very, very careful. Specific learning disorders, you can always come to know because the impairment will be through specific subject like mathematics or reading or comprehension. And when you go one-to-one intervention, supervision, a child with ADHD or ADD will improve, but SLD will not improve. So you have to identify, in that case, we have to get a more comprehensive assessment, we have to have more modifications, we have to add more support, all those things have to be taken. Anxiety disorder, again, it's very, very common, specific situation, mood disorder, medical condition and psychosocial environmental factors. In the end, my time is almost up. Overall, ADHD looks simple to diagnose, but it is not. After working in this field for more than 25 years and working with thousands and thousands of kids of ADHD autism, I can only say no two individuals of ADHD have identical presentation. Every child is unique, symptoms are different, that's why the interventions should be tailor-made. So the concerns expressed by the parents could include the child's academic underachievement, behavioral problems, social difficulty or low frustration tolerance. The incidence of comorbidity is very, very high. It's almost like almost present in most of the cases, and that can color the clinical presentation. Various other disorders may mimic ADHD symptoms. Differential diagnosis, careful diagnostic evaluation is the key. High parental tolerance for problem behavior may delay the diagnosis. Kuch nahi hota, chalta hai, it's okay, doesn't matter. I was also hyperactive, the chacha was hyperactive, the uncle was hyperactive, what's there? I also did well, but those times were different. The society was different. So yes, so those also can delay. ADHD is often missed in girls, adolescent girls, as they commonly present with inattentive symptoms, daydreaming, and fewer hyperactive impulsive. Some children with ADHD can focus on subjects of exceptional interest. Diagnosis may be difficult in preschool children. We are seeing a lot of children with 3 years, 4 years now with hyperactivity. That's what. Never be in a hurry to start treatment. Go slow, give time, and focus more on the psychosocial and behavioral intervention. That's important. Symptoms of ADHD may not be apparent in the structured setting of the clinic, or nervousness could be misinterpreted. There are no specific medical, neurological laboratory tests for making the diagnosis of ADHD. So, just last, so remember one thing. That's what I want to give you with these few points of my presentation in such a quick time. Information from multiple sources is mandatory. Don't get biased with one informant. Second, liaison with the child's world. Third, rating scales and laboratory tests are only supplementary. Your clinical evaluation is the most important. Fourth, evaluate for the comorbidity, which is a must. Fifth, consider other differential diagnosis. And the sixth point, patient and family education. Psychoeducation, educate the parents. Tell them it is not your fault. Work with the child, work with the family, and that is what is the way forward essential. Thank you very much. Thanks for your time.
Thank you, sir. It was a nice lecture, and you have given a lot of take-home points practicing pediatrician. Particularly, you have given the natural scenarios which a treating pediatrician encounters in the day-to-day practice about the various ages at which the hyperactive. So nowadays, parents themselves even bringing a 2.5-year-old child saying, "My child is hyperactive." These are the words which are commonly used by the today's parents. And you have given nicely when to label them and how to go about. And you have also given about mimics with the good differentiating points. Thanks, sir.
Yeah, thank you very much. Thanks for patient listening. And God bless you all.